ومسك الختام مع دكتورة مروة. اتفضلي معانا. هنتكلم عن delayed menarche or something different.
السلام عليكم. أنا دكتورة مروة مجدي نوار، مدرس بيدياتريك اندوكراينولوجي في جامعة عين شمس. النهارده هكلمكم عن حالة هي جات لنا مينلي في عيادة الاندوكراين، بتشتكي من delayed menarche وبس عايزة تعمل الورك اب بتاع delayed menarche. Yes. She was a 15-year-old female. She was just complaining of delayed menarche. She was the first order of birth of first cousin consanguineous parents. On examination, she had normal, her history revealed normal female genitalia at birth. They never complained of genital ambiguity. Her height, actually, she was tall. Her height was 169.7 centimeters, nearly 170 centimeters, plus 1.3 standard deviation, and her weight was 91 kilograms. So we examined her for Tanner staging. Her Tanner staging revealed axillary hair A3, pubic hair B5, and B1, no breast development. So she had a completely normal female external genitalia with no palpable gonads. However, her voice was virilized during speaking in a very obvious way, and this was one of her complaints. She had a weird virilized voice. So conventional karyotyping was actually ordered outside. She did it when she first started the workup of her delayed menarche and virilized voice, and it revealed the 46XX. And this was the picture of the conventional karyotype she did before. We ordered basal hormonal levels. So the basal FSH was 30. The basal LH was 26.6. These are actually menopausal levels. And her basal testosterone level was 1.13. And she had a low basal estradiol level. Her anti-Mullerian hormone was 6.5, which was good for a male level. 17-hydroxyprogesterone was not elevated. And her dihydroepiandrosterone sulfate was also normal. MRI examination of the abdomen and pelvis, and these were with her already when she came to us. It revealed non-visualized female internal genitalia, no uterus, no cervix, no ovaries, no vagina. And they sought to avoid intra-abdominal structures that have the appearance that could be testes. Okay, so to summarize, we now have 15-year-old normal female external genitalia, but A3, P5, virilized voice, and a 46XX karyotype with elevated FSH, LH, normal testosterone, no uterus, ovaries, or vagina, and two intra-abdominal structures that could be testes. So what would be the next step in this case? What would you like to do? Fish, okay. Repeat the karyotype, okay. Laparoscopy, okay. We did a laparoscopy and asked for gonadal biopsy. Yes, it was done outside, and we were sent, but they sent the video to us. في أمل نشغل الفيديو ولا؟
دلوقتي دي التستس ماشي وتحت.
Found one testis.
دي الخص اهيت. جوه مفيش رحم. انت هتمنطق الرحم بتاعك. ما حصل ضمور الخصيه اللي جوه. هات الرحم كده بقى. دلوقتي دي التستس.
He took a gonadal biopsy of the gonad he found, and it revealed prepubertal testes with moderate light axil hyperplasia, no germ cell neoplasia, no ovarian tissues, and no malignancy, thank God. The left gonad, he mentioned it was a streak, but actually he didn't take a biopsy, and also he didn't mention if he found spermatic cord attached to this streak or not, or even fallopian tubes. So now what's our differential diagnosis for this case? Maybe mixed gonadal dysgenesis, maybe ovotesticular DSD, maybe pure gonadal dysgenesis, but he found a clear testis. So we should exclude pure gonadal dysgenesis. So what would we do next? Remember, the karyotype was 46XX. Fish will repeat this karyotype, at least. So we repeated the conventional, actually, when she came to us. Or do fish, okay? We actually repeated the conventional, and it showed that all cells are 46XY. Okay? And we have the image here as well. So now what do you think is the final diagnosis? Probably a case of gonadal dysgenesis, XY gonadal dysgenesis. Mostly mixed gonadal dysgenesis. So what is the plan for management of this case? Yes, she has a completely female, normal female genotype, phenotype, so it's almost impossible to reconstruct her as a male. Her hormonal profiles reveal minimal testosterone secretion from these gonads, but they are not appropriate for her age, so they will probably will not push her into further puberty. So the plan will be for gonadectomy, and she has to be reared. She was actually reared as a female since birth, but they just came for this complaint, the delayed menarche and the virilized voice. So after gonadectomy, she's supposed to take hormonal replacement therapy in some form of estrogen and be raised as a female. So what are my take-home messages? Primary amenorrhea has a wide variety of underlying causes. Always correlate between clinical findings, laboratory, radiological, and karyotype results. If the results are inconsistent with the patient's clinical findings, they should be repeated. So we shouldn't take any results for granted. Okay, she has a karyotype, so it has to be right. She has an MRI, it has to be right. Okay, and thank you.
Thank you very much. We will leave Dr. Yasmin to close.
كان يوم مليء بالدي اس دي كيسز. انا عارفه ان كانت very overwhelming بالنسبه لنا كلنا كميه الدي اس دي اللي شفناها. To wrap up, لو في الchairpersons عايزين يكومنتوا اي كومنت.
عشان اهم messages, take very good history from the start. يعني examine the newborn very well. أي حاجة weird you have to consult, please, then it's always easier to diagnose and treat early. And thank you very much for everyone.
Thank you so much. وإلى اللقاء السنة الجاية.